Good afternoon, colleagues. Thank you for the opportunity to address you about this very important topic, namely the effect of COVID-19 on mental health. And I think this is the first time I'm speaking at a summer conference on the topic of COVID-19 and mental health, but I guess it's not the last time that a psychiatrist will be addressing a summer conference on mental health and COVID. So let's get right into it. And I would like to show you this article first and a conceptual framework which I like to use when I present on COVID-19 and mental health, because it helps us to retrace our steps and to look at actually what happened to us, and then it helps us to orientate us in terms of where we are at the present moment. And I'm sure we should be doing this every now and then. So this was an article by Roy et al. Named The Mental Health Implications of COVID-19 Pandemic and its Response in India. And shortly after the pandemic was announced by the World Health Organization, we look at what happened first, and I'll go into more detail in a moment. But what happened first, then what happened next, then who was affected, and then the mental health consequences there in the middle. And from the bottom up, it's more a matter of what are the intervention strategies that could be followed, and who the role players could be possibly to reduce the mental health impact on the general population and specifically on mental health care workers. And this afternoon, I'll be talking about not only the general population, but also the mental health care workers. I'll briefly touch on that because I think we all know that mental health care workers have been severely affected by the COVID-19 pandemic in terms of their mental health. So what happened first? We obviously had a countrywide lockdown. This happened in all countries around the world. But together with that, suddenly the schools and the colleges were closed, and children's lives changed, young people's lives changed. Our eldest son had to go to university, and suddenly a few weeks in, he was back at home and studying from home. The other one was in matric, and his whole life was different for a matric boy. So it changed the way that teenagers interacted with each other. Social media obviously erupted, and conspiracy theories abounded, and I'm sure you're all aware of that. But also we learned a new vocabulary by name of work from home, and it even found its own acronym. So offices were closed, and we started working from home. People started working from home, and office space suddenly had to go into the bedroom or into the living room or into the kitchen, and people had to get connectivity, and that changed the whole dynamics, I think, for the way that families were interacting with each other. Obviously, daily routines were changed. Suddenly you wake up in the morning, and instead of getting dressed and getting ready for your commute to work, suddenly you were basically getting out of bed and you're in front of your office, and this has affected a lot of people working from home. And you all know that the healthcare environment was severely disrupted as well, with pressure on the healthcare system. And the government frequently had to take measures to reduce that burden on the healthcare system. And then what happened next? We started getting used to social distancing. I remember the first week or two going to a shop and standing outside in a queue with my mask on and waiting to enter into a mall. And I remember the distress in the people's eyes next to me and in front of me and behind me. And I'm sure I looked probably just as scared as they did. Also, we couldn't meet with our family and friends, and we couldn't visit our parents. And we all had this fear of this unknown disease. What's going to happen? What does this pandemic mean to us? Up until this point in our lives, we've just been exposed to it in terms of media and science fiction stories, basically, and films that we've seen. And again, lots of misinformation was spread through social media and still is to this day. And with every wave, we saw an increase in patient load, the medical system being overloaded. And obviously, the other thing that happened is that people started closing their business. There was financial insecurity, and people weren't sure whether they still had a job the next week or not. And then it serves to remind us as to who was affected. Firstly, people who was affected by the virus itself. a lot of people died. Some of my family members have been affected, and I don't think, I keep saying to people, I don't think there's a person on this planet that can say that they have not been affected. Whether you are the person with the most money in the whole world, you can't say that you have been unaffected by COVID. So patients were affected, contacts were affected, survivors were affected, and family members were affected. The older population, the children and adolescents, I think needs special mention, because the older population suddenly had to self-isolate and couldn't see their families anymore. And then children and adolescents, I was a couple of months ago contacted by a friend of mine and said that his 16-year-old daughter is suffering from depression, in his opinion, and can I please assist in getting her an appointment with a psychiatrist. And he said it's because she says, I can't see my friends anymore, and I don't have the social contact that I'm used to. And then obviously people with existing mental illness was possibly exacerbated by all the measures that we had to take during the COVID-19 pandemic, which we are probably fairly used to by now, like sanitizing and wearing masks and social distancing. The general population was affected, and frontline workers all were affected by the COVID-19 pandemic. And what this article then says, and I'll go into a little bit more detail later on in the presentation, was that the mental health consequences were anxiety, depression, panic, stress, suicidal thoughts, and post-traumatic stress disorder. And at the time, I think we all tried to look into the crystal ball, into the future, and I was also one of those, to try and see, well, what is going to happen? What can we expect to happen in the next year or 2 or 3? So I wrote an article on the SAMA Insider and suggested that there might be a next pandemic. And I think that's why we're having this conversation today. And then also I wrote an article on mental health and clinical equipoise in the face of moral injury during the COVID-19 pandemic. And you are welcome to go and have a look at those articles and decide for yourself whether you think I got something right in the process. So when it comes to the consequences of COVID-19 recovery and the terms that we use, there's still not widely accepted definitions of the stages of COVID-19 recovery, but there's general agreement, and these are from the NICE guidelines on what acute COVID-19 is. And these are symptoms of COVID-19 for up to 4 weeks following the onset of the illness. And then you get the ongoing symptomatic COVID-19. Those are symptoms of COVID-19 from 4 to 12 weeks following the onset of illness. And then what I'm going to refer to today as long COVID is post-COVID-19. Symptoms that develop during or after COVID-19 continue for more than 12 weeks and is not explained by an alternative diagnosis. So how did it affect us? And this is without having had the infection. This is from up-to-date recent information. In terms of anxiety, you will see that healthcare workers, up to 1 in 5 had symptoms of anxiety, up to 1 in 4, 25% depression, post-traumatic stress disorder in nearly half of our healthcare worker population. Compared to the general population, I'd like to point out that moderate to severe anxiety, about 30%, so there's 1 in 3, moderate to severe depression, up to 17%, and then about 7% PTSD. And I noticed an interesting thing when I put these statistics next to each other, and forgive me, I tend to get carried away with statistics, but statistics puts things into perspective for us. But what I found interesting is the high number of depression in healthcare workers and the high levels of anxiety in the general population. And I suppose it has something to do with us as healthcare workers and medical practitioners that are more familiar with viruses, and we have the medical knowledge, but it doesn't leave us unaffected. And it's quite a scary thought to think that 1 in 4 healthcare workers might be suffering from depression at the moment. And then there's specifically those that had the virus itself. So the COVID infection up to 36% had anxiety symptoms, around 33% depressed mood. Again, look at it in a different way. That's 1 in 3 to 1 in 4 people. But most concerning for me, and I'm going to share a case with you a little bit later on that gave me lots of reason for concern, is memory impairment. During COVID infection, up to 34%. But in that long COVID period, anxiety and depression, about 1 in 5, 22%, PTSD, 24%, and memory impairment, 18%. So 6 weeks to 3 months after COVID. Remember, these are people that might be back at work. One of my interests is workplace mental health, and before I did psychiatry, I did occupational health. So I'm always interested in how a person's work is affecting them as a person, an individual, and vice versa. And I can imagine what this means for productivity if a person goes back to work and around 20% of them have significant memory problems. And then something else there that just, again, personally, where I think that no one can say that they are unaffected. I had to help a friend of mine in the past 2 months, whom I had a talk with. I had a conversation with him just this last week, and I said, I do think you need to see somebody now. I think you have post-traumatic stress disorder. And he was in hospital for 2 weeks, and it was touch and go whether he was going to go to ICU. And every afternoon around 4 o'clock, 5 o'clock, his anxiety would just suddenly start building up, and he would start getting panic attacks. And he said that time when he was in hospital, when the evening started to arrive, and it was after visiting hours, his wife was allowed to come in every now and then to see him, that he would start being afraid to fall asleep, because at night, he says, he didn't want to allow himself to fall asleep because he didn't know whether he would wake up the next morning. And he has all the criteria for a post-traumatic stress disorder at the present moment. So what is this long COVID? Very interesting. Apparently, from what I've been reading, is that long COVID is the first illness that got its name via social media and was given its name by patients and not by the medical profession. So it started with the terms long COVID or long haulers or long-term COVID, and then we went on to terms like post-acute COVID-19, chronic COVID-19, and post-COVID syndrome. So several terms are being used, but I think probably from what I'm seeing is most are sticking with the word long COVID, but I still put it into parentheses because I'm not sure what we will be calling it in a few years from now. And it is unclear if this represents a new syndrome unique to COVID, or if there is an overlap with recovery from similar illness like SARS and MERS and post-viral fatigue syndrome and chronic myalgic encephalitis. And my impression already at this stage is that we're dealing with something different. It's not similar to what we've seen before after COVID, after a viral infection or severe viral infection. So this is a lady that I saw for an insurance independent medical assessment earlier this year. And I'm sure that this is probably an outlier, but it confronted me with how unpredictable this disease is. So Mrs. M was a 59-year-old nurse with a 22-year work history. She was working in the COVID ward, one of the stalwarts, a very hard worker. Contracted COVID in June 2020, but did not require hospitalization at the time. She returned to work a month later, but reported forgetfulness. She was referred to a psychiatrist in November 2020, and the psychiatrist actually insisted on admission because she noticed that there were some problems with this patient's memory. She did an MRI, which was unremarkable, did a full organic workup, also unremarkable. What was concerning for her, though, was that on the MOCA is the Montreal Cognitive Assessment, is that she scored 19 out of 30. Now, below 26, we're starting to get really worried with the MOCA. And at the time, a differential diagnosis is this. She thought that the lady had a major depressive episode. Was this possibly post-traumatic stress disorder? And was she faced with maybe an early onset dementia? Shortly afterwards, her daughter was phoned by the lady where she lived. She rented a room, and the lady told her that her mum is struggling to look after herself, and she came to fetch her mum. And when I saw her a few months later, she was living with the daughter permanently. She needed 24/7 supervision. The daughter had to, when she went to work, she had to get a cousin to come and look after her mum, and she needed help with all aspects of her activities of daily living. I did a telehealth assessment on her, and then we do what is called the blind mocker, so we don't do the spatial executive part, and she scored, usually a normal score would be 19 out of 22. She scored 3 out of 22. So my diagnosis at the time was major neurocognitive impairment. And I was wondering at the time, I was really shocked. I was wondering how many people will present like this. And afterwards, when there are time for questions, I'm very curious as to whether there would be any similar experiences elsewhere in the country with doctors. So the bottom line is long COVID is an evolving problem with an extensive impact. It is still evolving. We're still figuring things out with long-term COVID. But the bottom line is it is a multi-system illness. Multiple systems are involved, and it requires a holistic approach in the management of long-term COVID. And although many persons with long COVID will be managed in primary care, others will require greater input from rehabilitation medicine experts. And this was an article by one of our local authors, Mendelssohn. From what I've been reading, I'm not sure if we have COVID-specific rehabilitation experts or centers in our country. I do know that there is something in the UK to that effect, as well as in the USA. But because there are multiple systems involved, we will have to have multiple professionals involved, or a multidisciplinary team involved in the management of people with COVID-19. And again, what I found on UpToDate, I'm not going to look at the common physical and less common physical symptoms and the percentages and the time there, but let me focus the rest of the presentation then on what we see in terms of the mental health care effects. So in terms of post-traumatic stress disorder, you saw earlier up to 1 in 4 might have post-traumatic stress disorder, and this is 6 weeks to 3 months after contracting COVID. Impaired memory and poor concentration, 18%, 16%. Anxiety, depression, 22%. So given the unknown long-term sequelae of those with persistent symptoms following COVID, the clinical protocols generally include a comprehensive physical, cognitive, and psychological assessment. So if you find a person who comes back, let's say after a month or 2, or you're a general practitioner looking after this person, they will probably come back to you and have a complaint around one of their organs. And if they've had COVID, I think it's time to really take things seriously and again do a complete physical examination, and including a cognitive and psychological assessment for which they might have to be referred to if there are any concern in this regard. And what is said is that care should not be delayed, and referral to pulmonologists, neurologists, physicians, and psychiatrists should happen sooner rather than later if interdisciplinary care is unavailable. Unfortunately, in South Africa, my experience is that we tend to work in silos in private practice. So when it comes to the general evaluation, the initial evaluation, you need to take a comprehensive history of the acute COVID illness specifically. So ask about the illness timeline, the duration and severity of symptoms, the types and severity of complications like DVTs, kidney injury, oxygen requirements, that they need ventilation, were there any cardiac complications, any delirium, and what the treatment strategy were specifically for this person. So that helps you again to retrace your steps, go back and say, okay, what was the initial presentation of this person when they had the COVID infection? And then verify the information with hospital records and review the discharge medication. Oops, sorry, I went a bit quickly ahead there. Now I've gone, apologies. verify your hospital records, and then review your discharge medication list with the patient to confirm the accuracy and make sure that the patient, what the patient says they were discharged on was the medication that they got. And again, this might sound as if you're checking up on the patient or the doctors. It's actually not that. I've seen a number of patients now for the insurance companies when I do my independent medical assessments. And one patient in particular stands out that actually did not have COVID, but he had a pneumonia during the time of COVID. And what concerned him the most was when he was discharged, he wasn't told what to do and how to take his medication. And well, that's what he says. I couldn't verify that of course. So it serves to ask the question specifically, and then just check with the hospital records. So I'm not going to go into the right side of that table, because that's not my field of expertise. But let's look at the neurological and neurocognitive symptoms, the psychological and emotional issues, sleeping disorders, and then fatigue, poor endurance, and functional status. And those are the symptoms that we see tend to persist after COVID. So firstly, neurological and neurocognitive symptoms. What can you expect, or what do you need to look out for? For example, strokes, seizures, hypoxic encephalopathy, neuromuscular weakness, and encephalitis. I spoke to a cardiothoracic surgeon recently, and he said that he knew of 2 or 3 patients that had an encephalitis picture, that their consciousness just became more and more depressed. So perform a complete neurological history and examination, evaluate the degree of residual deficits and the impact on the patient's functional status, and then specifically go and look at memory problems. It's not enough just to ask the patient, do you tend to forget things? Do a cognitive assessment, get a baseline of what the person's cognitive functioning is. So you can do the screen. The MOCA is, you're supposed to do a course these days for the MOCA, but I'm sure you can still find the MOCA on the internet. And then any patient that with scores indicating moderate to severe cognitive impairment, and they're talking about less than 18, should be referred for neuropsychological evaluation and management. But I'm going to suggest anything below 24, you should start worrying about a MOCA below 24 out of 30. With regard to fatigue and poor endurance, screen the patients for functional impairment. And this is where the multidisciplinary team comes in. It's your physiotherapist, your occupational therapist that can also be of assistance there. Determine the level of assistance needed for activities of daily living to inform the patient's rehabilitation plan, and establish whether any decline is due to deconditioning, weakness, muscle atrophy, pain, and or cardiopulmonary symptoms. And again, a real life example is my friend that I told you about earlier. And I was tempted to ask him for permission to actually present his case, but he's a good example of, not only does he have PTSD, this is a person who actually is a sportsman, and he plays several different types of sports. And he says in the week after discharge, just walking outside into the garden, his pulse rate would go up over about 140, and his SATs would drop immediately to around 92, 90. And only about, I think it's now 4 weeks since he's been in hospital, he can now already walk around the house without feeling too fatigued. And he's now thinking of going back to playing sport, and I'm not too sure he should be doing that without his doctor and his physio's blessing in that regard. But when it comes to fatigue and poor endurance, I think this is something that we need to ask a lot of questions, just so that we can understand what this person is going through. And for me, when I listen to him, it has nothing to do with muscle atrophy or pain, but it can be cardiopulmonary symptoms, and obviously deconditioning. After spending 2 weeks in hospital, you're going to decondition to some extent. And this was somebody that was really fit. And then how do you manage the persistent fatigue? I actually sent this to him. He missed it the first time. I reminded him the second time. And when he read through it, he said this was really helpful. So encourage adequate rest, good sleep hygiene, and specific fatigue management strategies. They talk about the 4 Ps. Planning your activities, pacing your activities, prioritizing what you're going to do first for the day and what you're going to do next, and then positioning. Literally ways to stand or to sit or to lie down to breathe easier. My slides will be available, and you can go onto that website, and it's a lovely PDF document that is freely available on the internet on how to for people recovering from COVID, and it's really practical advice. And I would encourage you to give that to all your patients. Not only yeah, I think it's a really nice practical document. Then, if patients have symptoms consistent with ME, myalgic encephalitis, or chronic fatigue syndrome, a similar management strategy is warranted. To be honest, I haven't seen this. My experience has not. This has not come onto the radar. These people are really, really tired, and it's a different type of fatigue and a different type of clinical picture than I've seen with people with chronic fatigue syndrome. And then patients with more pronounced limitations of endurance or exercise tolerance due to muscle weakness or deconditioning should be seeing a physiotherapist as well. Right, and then psychological and emotional issues. Symptoms consistent with anxiety, depression, and or PTSD. Evaluate the severity of symptoms and determine the most appropriate treatment. So I guess what I'm saying, I know I'm not necessarily addressing psychiatrists, I'm addressing a lot of general practitioners. Please go and have a look at your DSM again, and just have a look at what are the symptoms of generalized anxiety disorder, what are the symptoms of a panic attack, what are the symptoms of a depressive episode, and what are the symptoms of post-traumatic stress disorder, the flashbacks, the nightmares, the avoidance behavior, the change in cognition and mood, the hyper arousability. So just go and familiarize yourself with those symptoms again, and then determine what the severity is and what the most appropriate treatment would be for this person. And when it comes to mild to moderate anxiety depression, I strongly recommend that this can be treated by primary care clinicians. And in fact, I think that goes for most depressions and anxiety. About 70% should actually be able to be managed at a primary care level, depending on the practice setting, obviously, and the clinician experience and interest. And then patients with severe anxiety and depression, patients with PTSD, I would strongly suggest that you refer for psychiatric evaluation. When it comes to rehabilitation setting, the question is, should it be in person, or should we start considering home or tele-rehabilitation as an option? And that article that I quote, the remote delivery of rehabilitation services may be preferable in areas of high infection prevalence, was already published in 2018. I've embraced psychiatry and telemedicine. I think it's of course it's easier for us in psychiatry to use telepsychiatry, but I do think that we need to think out of the box, and I do think that telehealth is here to stay, and that we need to embrace it rather than try and avoid it. Because what's easier than sitting in the comfort of your home and helping a person in the comfort of their home, and going through a series of exercises. And this can be done by an occupational therapist, by a physiotherapist, by you as a general practitioner, by specialists. I think the one thing that we learned through this pandemic is that we actually can still connect with the person, even though it's on the other side of a screen. I heard an interesting word that was being used a couple of months ago, and that's that we need to improve our website manner, not our bedside manner. So this is our website manner. So we need to change our skills and to become more familiar with health as a way of reaching people that are for whom it's difficult to come to us. One of the most important questions for me, again, as a occupational health practitioner and somebody that's really involved in assessing people for readiness for return to work, is when should a person return to work? And remember, the motto is always, work is good for you. We want to get people back at work, obviously not at their expense, but a person who stops working is worse off than a person who can continue working. And I know I might get sidetracked by this topic specifically, but I too frequently see healthcare practitioners suggesting to people that they be medically boarded. So statistically, what they say is that your chance for a suicidal attempt increases by 6-fold from the general population if a person ceases to work. Your physical health deteriorates, your mental health deteriorates. People who stop working have more cardiovascular problems, they have more endocrine problems, their eating pattern changes, their sleeping pattern changes, they tend to eat more carbs, they start suffering from diabetes. I can't stress this enough. This is my passion, is to actually encourage physicians to do everything in their might to get a person back to work. Statistically, they say that anybody who's out of work for 6 months or longer, the chances of returning to work is only 15%, 15%. So we need to do everything we can to get a person back to work. But the ability of the patient to return to work or exercise should be assessed on an individual basis and will vary depending upon their baseline pre-COVID-19 functional status, the severity of the illness, and the type and severity of complications. So in general, for most patients recovering from their acute illness, gradual resumption of exercise as tolerated, starting at a low intensity level and then slowly increasing activity over the next couple of weeks. Okay, so who's going to work with these patients? A team. I think this is going to, COVID-19 is forcing us to return to a multidisciplinary team. We're going to have the GPs being the first contact point, like always, and then involving a number of specialists, be it a psychiatrist, a cardiologist, a pulmonologist, whomever needs to be involved in this particular patient. We need to involve the psychologist in this process as well. I encourage strongly my friend to go and see a psychologist and make an appointment as early as possible, because he needs to talk through this trauma that he had just experienced. Physiotherapists definitely involved in the recovery period, as well as occupational therapists. We underestimate the role that an occupational therapist can play, especially in that return to work time when a person may need reasonable accommodative measures, and to talk to the employer and say, this is what the person can do and this is what the person can't do, and how can we meet in the middle? Because again, I want to stress, for me, return to work is always first prize. So winding down then, a word of caution for all of you out there. Don't underestimate how this has affected you, how this affected me, how this affected us. We need to keep our clinical balance, our clinical equipoise. I think we're over the worst now. Initially, we didn't have enough evidence base to go on, and people went on bandwagon and said this works and this works. But slowly the evidence base is catching up. In fact, I say slowly, I think the evidence base caught up very quickly. But I would still encourage everybody to follow the evidence base in whatever your field of interest is. Don't underestimate the moral distress that you've experienced or are experiencing still and might experience with the next wave. Moral distress and moral injury is when we know what the right thing is that should happen. We know what the right thing is to do, but we don't have the resources to do it. And those very, very hard decisions that might result in one person living and another person dying, that's when the moral injury comes from. And that can lead to guilt feelings in healthcare workers, that can lead to feelings of inadequacy, and can then go on into anxiety and into depression. And I would really like to ask you colleagues to please look after yourself and don't underestimate your stress and your burnout and think that you have been untouched or that you're bulletproof or that we as doctors should just keep going. We are not superhuman. We are not untouched by all of the trauma that has been happening. So please, if you are struggling, please reach out. And I have put this in today here for you as healthcare workers as well. There are all the SADAG helplines, the South African Depression and Anxiety Disorder Support Group, with all their helplines. And then if you're not aware, there's also the Healthcare Workers Care Network, and there's a 24-hour helpline there. There's an SMS helpline, and you can also go onto the website. But please, if you're struggling, please seek help and please reach out to another healthcare provider to assist you. And that is, as they say, that. Thank you very much for your attention this afternoon. If you would like to, you're most welcome to reach out to me via email. Thank you.